Hi, everyone. Welcome to the program tonight, the latest in myelofibrosis treatments, what clinical trials are available to me, hosted by the Patient Story and the Leukemia and Lymphoma Society. I'm Stephanie Chuang with the Patient Story. I had a different blood cancer, non-Hodgkin lymphoma, and I went through treatment a few years ago. But I'm so passionate about these discussions because, as we know, so many things are happening in the landscape of changing treatment options, and they start with clinical trials. And we hear about clinical trials, but I think the term itself, I remember the first time I heard it, it was so daunting and overwhelming. And so our goal is that today you walk away with a much better understanding of what they are in human terms, and maybe some that might be right for you that maybe you can ask your own doctors about. So first, a little bit about the Patient Story. Our platform features hundreds of in-depth, authentic patient stories across cancers. Also, we feature top cancer specialists, voices like the ones you'll hear tonight. And our goal is to humanize cancer and help you navigate life after a diagnosis, whether you're a patient or a caregiver. You can join our community and you'll get first access to programs like these with new updates and new stories. And we're so proud to be co-hosting this also with the Leukemia and Lymphoma Society. It is the world's largest nonprofit health organization dedicated to funding blood cancer research, so critical, as well as offer patient services and education. There are great resources if you haven't checked them out yet. There are their information specialists who are just a phone call away to help you answer some cancer questions. And also they offer help to pay for cancer costs, like a copay assistance program, and also with travel, maybe sometimes with things like CAR T-cell therapy or clinical trials. We also want to take the time to give special thanks to GSK and Karyopharm for supporting our free independent patient education program. We want to stress that the Patient Story and the LLS retain full editorial control over the entire program. And also, lastly, I want to say this is not medical advice, not meant to be a substitute. So please just make sure to talk to your own healthcare team when you're making any decisions. One last housekeeping item, promise, before we get to the introductions tonight, and that is we really want to hear from you. Your voice is incredibly important, and that feedback is so key for what we do next. And so once this window closes, a survey will pop up. It'll only take a few minutes, and it'll ask you, if it was impactful and what topics you'd like for us to cover. So once you complete that, it'll automatically enter you into a raffle for a couple of $50 Amazon gift cards and a small thanks for your time. All right, now it's time to go into introducing our incredible panelists for this discussion tonight. First up, really lucky to have Dr. John Mascarenhas, Professor of Medicine at the Icahn School of Medicine at Mount Sinai. And get ready, there's a long list coming here. Director of the Center of Excellence for Blood Cancers and Myeloid Disorders, Director of the Adult Leukemia Program, and also leads clinical investigation within the Myeloproliferative Disorders Program. And that's not the entire list, just the ones that we could fit on screen. So Dr. Mascarenhas, really appreciate you being here. I had heard you self-describe somewhere else about being tireless and working nights and weekends, which you clearly do, including for tonight's discussion, to help patients in this space. So we really want to understand what drew you to MPNs and to continue to do this work for patients.
First of all, thanks for having me join you guys tonight. So my interest began in the laboratory doing leukemia research many years ago now, and then evolved over time into clinical research, in which I was introduced to MPNs and really gravitated towards it. This was at a point where we didn't have JAK inhibitors. It was sort of a sad space to be involved in, and then I was right at the right time where the discovery of the JAK2 mutation came out, and got involved in the early development of JAK inhibitors and have watched the field blow up. And for me personally, it's been really exciting and rewarding to see this transition from how we used to treat patients with myelofibrosis and other related MPNs to what it looks like today. So I'm very enthusiastic and optimistic about the future, and happy to join you guys today.
Oh, thank you, Dr. Mascarenhas. And we love hearing it. Exciting, optimistic. We know that the landscape has shifted very quickly in a short amount of time, and excited to talk about it tonight. So again, thank you for being here. We're also really excited to have Dr. Tania Jain here tonight, another MPN specialist. She is an assistant professor of oncology at Johns Hopkins Medicine, director of the Adult CAR T-cell therapy program at the Sidney Kimmel Comprehensive Cancer Center, with myeloproliferative disorders as a top area of interest, and studying newer drugs in early phase of development. So another long list of amazing things that you do, Dr. Jain. Thank you for joining our discussion. And we'd also love to understand what drew you to the MPN space, and also, what's the driver of doing this work for patients and their families?
Thank you so much, Stephanie, for the introduction and for having me here. I'm absolutely delighted to be a part of this panel. So for me, I don't think it was a specific event. I think it was a natural transition during fellowship under the mentorship of Dr. Ruben Mesa and Dr. Jean Palmer, who've obviously done a lot of work and continue to do so. And how that sort of transitioned me was to recognize the significant unmet need in the space and the load of opportunity that existed to contribute to improve outcomes for patients, to improve lives of patients and their families. So that's kind of what we try to do.
Thank you so much. And that means a lot for all of us who've gone through cancer. Speaking of just incredible work too, we have someone representing the Leukemia and Lymphoma Society's Clinical Trials Support Center, which we'll be talking a lot about. It's a really great resource because, as we know, clinical trials, very daunting, can seem like a lot to wade through. So Ashley Giacobbi, thank you for being here, Ashley. And by the way, you being a nurse, I have such a special place in my heart for nurses. I remember going through my chemotherapy, my treatment, and nurses being such a lifeline. So really appreciate the work that you do. We'd love to understand more about yourself and what drew you to this calling.
Well, thank you so much, Stephanie. I'm really honored to be here today. I have been a nurse for almost 20 years now and really have enjoyed all of my time at the bedside, but I find I get extra excited, as has already been expressed, when we're talking about new changes and just how much has changed in the world of oncology over the last 20 years. So it's exciting. It's exciting to be able to help patients find clinical trials when they're seeking that newest level and next level of care and some of these new developments and advancements that we've had.
Wonderful. Thank you, Ashley. And I know that we'll be really talking about some of the top topics you're getting from patients and care partners who are calling you, asking for your help in the clinical trial space. And finally, we've got Mary, who I'm really blessed to be able to call a friend now. She actually lives in my neck of the woods here in the Bay Area in California. Mary, you are a myelofibrosis patient advocate. You lead a group on Facebook with myelofibrosis patients and care partners. We're so lucky to have you here to share your perspective tonight as well. But can you describe yourself a little bit outside of cancer? Because as we know, we are so much more than a diagnosis.
Yeah, thank you for that. I am so much not defined by my myelofibrosis. I am an almost 61-year-old woman. I am a nurse as well with both a bachelor's and a master's degree in nursing. I have stopped clinical nursing now for 25 years. I've been in executive leadership. I'm currently the CEO of a small nonprofit foundation that basically mostly runs a retirement community here in San Francisco. I'm also a mom to two amazing adult sons who are launched and living on their own. One is married, one is about to get married, and I'm really hoping for grandchildren soon and to live long enough to really enjoy those grandchildren.
So let's set the stage, Mary, first with a little bit of your story, because like so many of us experience, a diagnosis changes our lives. And for me, it was a different blood cancer, it's non-Hodgkin lymphoma. And tonight we're talking about myelofibrosis. So for you, what led you to figuring out that something wasn't right? And how did you get that diagnosis with primary myelofibrosis?
It wasn't easy, first of all. I was about 54 and a half, and I started with vague symptoms. I had fatigue, I had dizziness, sometimes vertigo, to the tune of like wish and then fall. And I knew something was wrong. I thought maybe I had mono or Lyme disease or something like that. I felt like I needed to nap more frequently. I felt like if I walked up any incline, I needed to rest. And I kept complaining to my primary physician about these symptoms, and he kept telling me I had menopause, which I had long been through at that point. And I repeatedly would go back to my primary physician and say, please, let's investigate what this is. And even told him that my father had a rare blood cancer around the same age. Finally, 6 months into begging, I just reached out my arm to the doctor and I said, I'm not leaving your office till you do a Chem7 and a CBC. And he did. And 3 days later, I got on my chart, I got the results that I had platelets in the 800,000s. So of course, Google became my friend. And I called the doctor and he refused to talk to me. He said, I'm sending your blood off for special testing. I said, what testing? He said, I don't want to tell you because I don't want to scare you. And so I started Googling and I was pretty certain I had probably an MPN. So 3 months later, I found out that I had the JAK2 mutation, and I didn't find it out from my primary who did the blood testing. I found it out by getting a call from the oncology center admitting me to services. So when I walked into the oncology center, had a very strange experience. The oncologist who treated me first, or the introductory oncologist, said to me, I know you're probably really afraid of the C word, so we're not going to talk about it. Let's talk about it like a blood disease. And I told her, as a nurse, you don't have to do this. And then she said, and the other C word is an evil drug, so we're not going to talk about that either. And so I kindly asked her to get me another doctor and then sought a second opinion. At that time, I wasn't so afraid of dying as much as I was afraid of not having the information I needed to live well. I didn't know if my life was going to be shortened, and I wanted as much information as I could get.
Yeah, no, I really appreciate you sharing all that, Mary. Thank you. And I also love this message of self-advocacy and empowerment. It is, your life, your body, and you certainly didn't let that fall through the cracks. And I think that's really powerful. And this discussion is meant to share the valuable information, hopefully for people to walk away with. It's not medical advice, but it is something that will help people maybe go to their own doctors with. So I want to kick off with a question to Dr. Jain to again set another stage, which is, Dr. Jain, what is myelofibrosis, if you can, in layman's terms, and what are some of the more common maybe first signs or symptoms?
Yeah, so what we heard here is something that's something that I hear in clinic fairly commonly, and having that fatigue, having the tiredness is something that often takes patients or people to physicians to get tested. And there are delays. That is not uncommon either, probably because fatigue or tiredness has several reasons to it, or several possible reasons to it. Some may be more common than the others. But you also mentioned that you have the JAK2 mutation, which is of relevance here, and probably how I will start, because The basic or the premise of myelofibrosis sort of starts with the overactivation of JAK-STAT pathway, which is supposed to be a normal functional pathway, supposed to do the regular stuff and make blood cells. But when it's overactivated or activated without any restrictions, that's when things happen, or undesirable things happen, which can include affecting the bone marrow function in a negative way. So either you could be making too many cells, like your platelets were 800, which is relatively high, or you could alter the bone marrow function in the way that there is more scarring in the bone marrow, the fibrosis in the term myelofibrosis, which again affects the ability of the bone marrow to function normally, which is its job to make normal quantity and quality of blood cells. And as a result of that, patients can get anemic or have low hemoglobin, which can cause the tiredness and the fatigue and difficulty breathing and symptoms related to that. The other piece of things that can happen is, again, by virtue of the JAK-STAT pathway activation, is this systemic or generalized inflammation piece of this that we often notice or have patients, lead them to a workup. And what that results in is what we in our clinic call as constitutional symptoms, or symptoms that are, again, could be non-specific or vague as sometimes labeled, but those can include things like night sweats, things like low appetite resulting from, or other symptoms resulting from an enlarged spleen, abdominal discomfort, and so forth, which are, again, other symptoms that can sometimes lead to further investigations clinically.
Thank you. I know that's a lot to cover in a short amount of time, and we do hear lots of stories, right, about how long it can take to figure out a myelofibrosis diagnosis, and so that's not unique to Mary's situation. Dr. Mascarenhas, you had alluded to already in your intro just how optimistic you are because there are so many developments happening. We're going to delve into the specifics of different clinical trials and the research happening in just a bit, but on a higher level, how would you describe the landscape shifts that have happened in myelofibrosis treatments, especially in just the last few years?
So, myelofibrosis, as Dr. Jain put very nicely, is a stem cell derived cancer, blood cancer, and it can affect people in different ways. And one of the things I think is really important to impress upon the audience is really you don't meet two people that walk the same path. They all really come in different forms and fashions. Their clinical picture can really vary, and then their course can be quite heterogeneous and variable too. So you really have to sort of understand the patient that you're dealing with and what might be those patient-specific goals of therapy. For some patients, it could be alleviation of anemia. For other patients, it could be the systemic symptoms, the fevers, the night sweats, the weight loss, the bone pain, the profound fatigue that can be quite debilitating. And for many patients, it could be this enlarged spleen or liver that's really causing a lot of discomfort and challenging just normal activities of living, like bending over and doing things that would normally be easy to do. So sort of knowing how the disease is affecting the patient really informs and dictates how best to approach the patient. So it's typically trying to alleviate the symptomatology and reduce the spleen, and that's usually using JAK inhibitors. And over the years that we've grown to have 3 clinically or commercially available JAK inhibitors: ruxolitinib since 2011, fedratinib since 2019, and pacritinib since 2022. And we're likely to have a 4th one, momelotinib, later this year. And this provides a lot of opportunity to try to address those symptoms. Those cytokine-driven symptoms that Dr. Jain explained are a result of this JAK-STAT pathway. So these drugs are great in reducing a lot of that inflammatory cue that makes patients feel terrible and awful, and improves their sense of well-being, their functionality, reduces their spleen so they can eat more comfortably and wear pants more comfortably, things that we kind of take for granted. And in doing so, I think patients have a better quality of life and will, by virtue in most cases, live longer because they can do the simple things that we need to do. They can move and they can eat, and people who move and eat will simply live longer and do better than patients who cannot. And that's just generally true in oncology. So they have really revolutionized, I think, particularly the quality of life aspect. And as Dr. Jain pointed out, she worked with Dr. Mesa, who was really sort of instrumental in measuring quality of life and making that an endpoint for clinical trials, and bringing the attention to symptomatology. And and quality of life. So I think we have a great armamentarium today that covers lots of different types of patients to improve the symptoms and improve that quality of life. And we are developing drugs now that are looking to try to improve anemia. So historically, we use drugs like Procrit or Aranesp. These are erythropoiesis stimulating agents to try to improve hemoglobins, get patients out of the transfusion suite, give them some more energy back, or drugs like danazol, synthetic male androgen, or even drugs that we repurpose, which is a common theme in oncology, repurpose from other diseases like multiple myeloma. We use drugs called IMiDs or immunomodulatory drugs, like thalidomide or lenalidomide or even pomalidomide. And these can all be used in myelofibrosis off-label, I will point out, to improve hemoglobin with responses of about 20 to 30%. So the reality is we can improve hemoglobin in some patients, we can improve symptoms and spleen, but there's still really a lot left to do. And I think that's when I say I'm optimistic that work that we collectively do, that Dr. Jain, myself, and many other dedicated clinical investigators do, really makes I think the future bright and exciting.
I was just going to say, Dr. Mascarenhas, you answered my next question, but could you tell us a little bit about how those JAK inhibitors work, and then walk us through not only the ones that are available, but what are their benefits and limitations?
Sure. So JAK inhibitors are a class of agents, actually, interestingly, invented in the setting of this disease, and now actually have applications through a lot of different diseases that are not even malignant. And what they do is they intermittently reduce the signaling pathway Dr. Jain was explaining that is inappropriately activated in the bone marrow cells. And this pathway is responsible for, causing proliferation of blood cells and elaborating inflammatory mediators. And they intermittently quell this cascade of events, and that reduces the propensity to have this inflammatory state and this overproduction of blood cells. And what that seems to do is improve symptoms by reducing cytokines, which are these inflammatory byproducts. Patients feel better, and patients can move and eat and restores vitality. For reasons that I personally don't understand, and I've never seen a good explanation for, it also reduces the spleen. It's sort of a phenomena I don't really understand why. It's really an interesting aspect of the drug. So we know it reduces spleen, it reduces symptoms by reducing the activity of this pathway. Unfortunately, what it does not do, any of these drugs do in the JAK-STAT pathway inhibition class, is they don't induce remissions. They don't kill the what I would call the maternal stem cell, the grandmother cell that gives rise to all of these abnormal cells. It doesn't get rid of that cell. So it really kind of quiets down what's happening in the bone marrow and the spleen, sort of allows for some degree of normalcy, but the malignant cell population still remains, in the body, in the bone marrow and in the organs. And unfortunately, we don't see changes in the bone marrow that would, lead us to believe that we've remitted the disease. So the disease kind of sits there. Myelofibrosis is in the name. You have scarring in the bone marrow that typically remains, even while patients are enjoying the clinical benefits of the drug. And then there's the potential for downsides of the drugs. I mean, they often will exacerbate cytopenia. Cytopenias are low blood count. So anemia and thrombocytopenia, low hemoglobin, low platelet count, can often get lower with these drugs. We've sort of pivoted to try to develop drugs that may not be as myelosuppressive as count reducing, and may even improve some of the blood counts. So pacritinib, approved last year, is a drug that can be delivered in patients with low blood counts, less than 50,000. And in about 25% of patients can improve the hemoglobin. And momelotinib, a drug that's in late stage clinical development, awaiting FDA approval, has also been associated with improvements in blood counts. And what we now know, which we didn't know when we started off in all of this, is these drugs are not just JAK inhibitors. They're actually very dirty drugs. They are kind of promiscuous. They interfere with a lot of different pathways that may be relevant and irrelevant and cause toxicity. So, for example, inhibiting ACVR1, which is another pathway that's important for iron availability, might explain why pacritinib and momelotinib improve hemoglobins, and why maybe ruxolitinib or Giacobbi and fedratinib or Inrebic don't. And so there's a lot of nuances with these drugs that help us understand why they may fit niches and help certain people in certain ways, and why you can provide serial JAK inhibitors. So if you fail one, it doesn't necessarily mean that you wouldn't enjoy some response to another. So one can go from one to the other. And I think the tailoring of the JAK inhibitor really is somewhat of an art, not more than a science in some cases, and requires, again, what I would say, is knowing the patient, knowing what the goals are, and trying to match the potential goals and potential toxicities to that patient.
Thank you for that. And I've often heard that it's not, we're not getting rid of our JAK2 inhibitor, but we're maybe turning the volume down on it a bit with the use of these drugs. And it leads me to a question to you, Dr. Jain, is how do you know which JAK inhibitor might or might not work and which one to try first for a patient?
Yeah, that's a great question. And I'm going to sort of piggyback on what Dr. Mascarenhas was alluding to, and emphasize on the point that he said that no two patients with myelofibrosis will be the same. Everybody will have their own presentation or a different presentation or different things that you'll need to address or improve in a particular patient. And everybody will have a different trajectory in terms of the course of their disease, course of their myelofibrosis. And that is what is important to recognize as you're thinking about what you're going to start a patient on in terms of what your choice of JAK inhibitors is going to be. So a lot of times I tell my patients, we don't have the same treatment for everyone. We're looking at what we need to address in you as a patient. So for example, if there's someone where we're trying to address high counts, perhaps a JAK inhibitor makes sense, or if they will usually have a big spleen and symptoms or symptoms that will need to be addressed in combination with that. And for such a patient, a JAK inhibitor would make sense, usually probably based on the fact that we have the longest experience with it. Ruxolitinib or Giacobbi has been sort of our first go-to. It was, the first approved about a decade ago. And we sort of feel more comfortable with it. We know how to sort of, dose adjust it, and we sort of know how to, move things around with it. If that doesn't work, then the go-to next step in an ideal world would be a clinical trial. Obviously, clinical trial, even in a first-line setting, but something after Giacobbi, in an ideal world, would be a clinical trial. But if we do not have one that would fit, would be either fedratinib or pacritinib, and the choice would depend on where the blood counts stand at this point. So, for example, if the platelets are on the lower side or the cell counts are on the lower side, pacritinib would probably be a better choice. Obviously, there are patients who do not have spleen or symptoms as a major presenting thing, and anemia is a major presenting thing. And in those situations, as Dr. Mascarenhas alluded to as well, options such as Procrit or danazol, and hopefully momelotinib in the future, pacritinib to some extent, are some of the options. Luspatercept is in clinical trials. We'll see how that pans out. So those will be some of the options. And then the third set of patients is those who come with a more advanced disease in the way of more excess or higher fraction of blasts or leukemic cells or very, very early cells in the bone marrow. That indicates that these patients are perhaps headed towards a leukemic transformation or headed towards the pathway of a more aggressive pattern of disease like leukemia. And in those situations, either in combination with JAK inhibitors or without, something like hypomethylating agents could be considered, usually en route to a bone marrow transplant, if that makes sense otherwise in terms of eligibility. But those are some of the scenarios that one would think of as we encounter patients with MPNs.
Yeah, thank you so much, Dr. Jain. What's clear from both of you is, again, this is very individualized, right? Decisions, and there's so many considerations, and that's where we hear people talk about, hey, go see a specialist, see a myelofibrosis specialist or an MPN specialist, and we'll be talking about that throughout the discussion as well. I'm going to shift gears a little bit just to set a different stage now in terms of clinical trials. So we've been talking a lot. We've talked a little bit about some of the things, the drugs, combinations that are in study now. But let's humanize this a little bit, because I remember the first time I heard the term clinical trials, I was like, that's really kind of jargony. I don't really know what that is. It feels a little daunting. So, there are lots of things that I think are misconceptions about clinical trials. we do know that, different stakeholders are trying to research what can be better to improve the standard of care for different patients and patient groups. And one of the challenges is that people view clinical trials as, for instance, a last resort, but just as Dr. Jain, you referred to, in some cases, you're hoping that's the second line of treatment or a second option for people. So let's bring in Ashley from the LLS to, again, humanize this a little bit. Ashley, we've heard, for instance, and we know clinical trials might not be right for everybody, right? But that they are an access to, say, tomorrow's treatment today. And we're sure you get lots of questions in your role there at the LLS. So what are clinical trials in layman's terms? And what are some of the top questions and maybe misconceptions you hear from people?
Absolutely. Clinical trials are carefully controlled research studies, which are conducted by doctors, researchers, scientists. And as we've already talked about, they may be investigating new therapies, or they may be investigating therapies that we've used in the past in potentially a slightly different way, or even in combination with other therapies, to really find out which works better. Or again, as we've talked about quality of life, potentially which might have fewer side effects or improve the side effects that patients are experiencing. And so looking at both tolerability of any of those types of treatments, as well as the effectiveness of the treatments. And so in general, that's what a clinical trial is. But again, regarding questions and misconceptions, there really are so many misconceptions out there. And it's hard to summarize them all, but certainly one of the largest is that it is for patients who have exhausted all options. And so as we've already talked about, that is simply just not the case. In reality, there are clinical trial options at all stages of diagnosis. As well as both interventional trials, which are those that are testing treatment options, as well as observational trials or registry trials, which may be there to help us really learn more about myelofibrosis as a diagnosis, but may not involve specific treatments. Other concerns that we regularly hear about are the use of placebos. The name placebo has definitely gotten a bad rap. A placebo can be known as a sugar pill. They are not very commonly used in cancer clinical trials because it just wouldn't be right for us to use a sugar pill in place of somebody who needed active therapy for a serious or life-threatening disease. But when placebos are used, it would be used in the setting where either a patient wasn't requiring any type of treatment in that particular moment, or potentially where it would be used in combination with another therapy so that the patient is continuing to receive active therapy for the disease that they have. Again, common misconceptions are some of those logistical concerns that may come up as well. So we always like to chat with patients a little bit about travel for clinical trials, what that might entail. We've talked about some of the academic medical centers and how important it is to have a specialist who's really an MPN specialist. And that holds true in the clinical trial setting as well, where very often the investigators who are looking at clinical trials for myelofibrosis are those in an academic center. We're certainly always encouraging and pushing for those clinical trials to be available in the community setting, but traveling to and from those academic centers can be a real challenge for patients. And again, financially, in addition to the logistical travel considerations, sometimes there's some misconceptions that clinical trial participation is free, or that patients may even receive money for participating. And unfortunately, that's not always the case. So it's really important that we go through that and we explain to patients that financially the parts of the clinical trial that are investigational or are not approved will be provided by the clinical trial. But very often there are outside components as far as physician visits or lab work. And very often those are things that we would expect a patient to undergo if they were receiving standard of care that may still get billed back to the insurance company or may have to be paid for in another manner. So there's lots of nuances. Each clinical trial is structured a little bit differently, and it's hard to know from an overview, but really it's important to have some of those general understandings before we dive into any specifics on any clinical trial. Again, as we talk about finances, those travel expenses, sometimes food or other expenses, parking, things like that. If you are participating on a clinical trial, occasionally there can be stipends available from the clinical trial to support the patient or caregiver. And that's why it's so important with each clinical trial to reach out and to find out more to make sure that you have all the information you need as you're making a decision about participating.
Thank you, Ashley. So important to hear that we do have access to medication, not necessarily the placebo. I think a lot of us do worry about that. and to know that we need to check in to find out what is available to us in terms of funding for clinical trials. Let's talk about single drug therapy. There's a new drug that's not yet FDA approved, momelotinib. When can we expect to see that approved, and what patient might it benefit?
Sure. So momelotinib is a JAK inhibitor. So it's much like ruxolitinib, Giacobbi, except as I mentioned before, there's some nuances that make these drugs a little bit different. So it also inhibits ACVR1, which is another pathway that regulates iron availability for red blood cell production. So really in its long development history, it's really differentiated itself from the other drugs in large part by its ability to improve hemoglobins in a subset of patients. So it went to the FDA based on a study called the Momentum study for approval. And the expected approval actually was late June. It was delayed, which is not uncommon by the FDA. And I would encourage patients to discuss with their physicians if that drug might make sense for them, or any of the other drugs that we've talked about, whether it's fedratinib or ruxolitinib or pacritinib. And I think as we've said, it really has to be tailored to the patient. So although I'm excited to see momelotinib come up, and for a physician, it's great because it gives us different options. So for the patients, different options. For the physicians, it also allows us to tailor the treatment for each patient. And that might be a great opportunity for some patients to either embark on that therapy or perhaps switch. And just to bring the point again that Ashley gave really nicely is the clinical trials set the tone for the interactions with the FDA about what that label will look like based on the way the clinical trial was designed and ran. So we don't yet know what the label will look like for momelotinib. We can only kind of guess based on how the clinical trial was run, that there may be stipulations. It may be that momelotinib may only be available after the use of a first-line JAK inhibitor, or it may be that it might have to have certain requirements for anemia level or depth of anemia level. So there are some nuances that sometimes play into the decision-making as well. And usually these are based on the clinical trials that led to the approval.
Thank you. I know too, Dr. Jain, there is combination therapy to think about. And I have a new question coming in from June F. What are the best drug combinations at present? Can you introduce us a bit to combinations in drug therapy?
So I'm not sure if I can answer what is the best drug combination right now, but I think that is a question that hopefully we will learn more and more about and hopefully address in the future. But there certainly are drug combinations that are promising, which, in the clinic means that it brings options for patients, options that we can offer to patients. Mostly on a clinical trial right now, but certainly some that hopefully will move the field forward. So the sort of basis of this is that historically we have addressed the JAK-STAT pathway, right, which we have learned the most about in the last couple of decades. And that probably is the primary pathway involved in the pathogenesis or the occurrence of myelofibrosis. But as we have learned more over the years, there are other pathways which may not be primary, but certainly critical to the development of myelofibrosis. And that is where the rationale for drug combinations comes in. And we've seen several clinical trials in the last few years that have addressed that or used combination therapy in patients who are not having a good response to Jakafi itself. And need more than that. Many of those drugs have been tested even in first-line setting to see if people or patients would do better with combinations up front rather than Jakafi alone, which has been the long-standing go-to first-line treatment for over a decade now. Some of those pathways, some of the drugs that you'll hear about, navtemadlin, for example, which is an MDM2 inhibitor. Dr. Mascarenhas presented that data at EHA a few months ago, showing responses in about 1/3 of patients. Depends upon how you define a response, but 35% spleen reduction in about 1/3 of patients in patients who weren't responding to Jakafi or ruxolitinib itself. There are BET inhibitors like pelabresib that I heard Dr. Mascarenhas actually talk about at ASH, which also is now being tested in the first line in patients who are starting upfront treatment. There's BCL-XL inhibitors like navitoclax, which have shown some improvement in second line setting, and we're awaiting public announcement on the data for first line trial. And there are others, right? So the premise is that you're combining two mechanisms that you that have shown to work in this diagnosis, and you're trying to combine drugs such that you do not have overlapping toxicities, right? So that's an important piece to remember as well, because JAK inhibitors can have, can cause some decrease in blood counts, or at least we've seen that with ruxolitinib. And you probably want to add a drug that may not do that as much, or may not do that to an extent that makes it prohibitive of a combination. Then, for example, with pacritinib, patients often would get sort of gastrointestinal toxicity. So probably don't combine a drug that may also have gastrointestinal toxicity. So I think that's important to remember as we think about combinations, which we will see more and more coming up in the future. And then I certainly want to emphasize the point of logistics that was brought up by Ashley and also by you, Mary, to some extent. Those are certainly important to consider as we're thinking about clinical trials, what the trial offers, what are the frequency of visits that you may need to the center, and whether that makes sense in terms of continuing to be on it or not.
Thank you so much, Dr. Jain. Dr. Mascarenhas, if you would just follow up with what should patients ask when considering a combination therapy that, like Dr. Jain just talked about, and how do we know when it's right or the right time to start one?
So I think that probably the first question to ask is why this combination for me? Like what would be the advantage in my case in terms of addressing goals of therapy? And then importantly, what are the potential risks? So, as physicians, I'm definitely included when I say this, we often focus on the positives and focus on what we think is going to be the advantage of participating in a clinical trial. But the reality is that sometimes, there are disadvantages, and there can be toxicity associated with approved drugs and unapproved drugs that are in clinical trials. So I think what patients want to understand is what would be the goals for them personally in participating in this trial in terms of expectations of results, and what are the potential known or in some cases, if it's an early trial, potential toxicities that one could incur, and then what does the patient need to be aware of as they go along in the trial in terms of mitigating and reporting. I think a trial is not really a passive experience. It's actually a very active experience where the patient is an active participant, not simply receiving a drug, but has to be very willing and engaged to report all symptoms, not to report what they think might be important, but to report everything to the study team. And that might sometimes mean calling ahead of their visit to let the team know what's going on, and making sure that all their medications are accounted for, and that they're following up, because it is an opportunity to assess whether a drug is active, but also to adequately characterize the toxicities of a drug, so that as the drug moves along, perhaps for patients in the future, that it's optimized in delivery for those patients. So, it's really two objectives. One is, how is this drug going to help me, and what is my role in this whole process? It really should be a joint venture. It's not a one-sided experience, and we learn from the patients. Hopefully, the patients also, the patient community learns from what we're doing, and everyone benefits.
Thank you, Dr. Mascarenhas. If I may, Dr. Jain had set up really well the sort of landscape of the combination therapies and talked about different options. We did get some patient questions about specific combinations, and so it'd be great to run through a few of those. And maybe we can start with selinexor and a JAK inhibitor. I think a lot of these are JAK inhibitor plus maybe a novel drug or.
Sure. So I think the first thing to point out to the listeners, and I always try to make it a point when I'm seeing patients in the clinic, is that clinical trials today are unlike, I would say, in large degree, what clinical trials were historically. And what I mean by that is these drugs are all rational with preclinical data that supports them, and they are, they go through enormous amounts, and people don't always realize this, enormous amounts of testing through various aspects before they ever enter a human being. So there's an enormous amount of regulatory burden that exists. That's really annoying, but really important to do, because it provides that certain sense of confidence in the investigators, but also in the patients, that what we're introducing makes sense, that we're not just taking something off the counter and saying, I wonder if this is going to work, and throw it into a clinical trial. So these are rationally developed drugs. So example is selinexor. So selinexor is a really interesting drug. It's a drug that's already approved for blood cancers that are not myeloid cancer. So blood cancers on the other side of the fence. So these are diseases like multiple myeloma and other B-cell lymphomas. And this drug is a drug that affects the shuttling of proteins in different compartments in the blood cell, in the nucleus and the cytoplasm. And why does that matter? Because if you can affect where proteins are in a cell, you can affect the function, ultimately the functioning of these proteins. And what selinexor does is it inhibits this shuttling protein, and thereby affects the way certain proteins that might be important to the pathophysiology of the disease from exerting their function. And this might even turn on other proteins and put them in an area where they can actually induce a good effect. So for example, there is probably a multitude of different changes, some of which I don't think we even fully understand when you use a drug like selinexor, that shifts the cell's functioning from one in which it's acting inappropriately and nefariously, into one in which you try to induce it to die through normal mechanisms. So there are normal mechanisms that are built into our cells that if they get corrupted by a virus or by cancer, that they turn on this mechanism called apoptosis, and they undergo programmed cell death. And cancer cells have ingeniously figured out ways to get around that. And we struggle each day to figure out ways to get them back on track, to commit suicide, essentially, to encourage them to recognize that they're inappropriate and to undergo this programmed death. So selinexor is a great example of a drug that affects multiple pathways, that really induces the myelofibrosis, perhaps even stem cell population, the primordial cells, to undergo this process of death. And it works best in combination with ruxolitinib. And that's a common theme that we've seen, is that in oncology, it is very rare, except for maybe CML or some other diseases, where we use monotherapies. In most of oncology, we use combinations of therapies to synergize together, and as Dr. Jain said, to try to avoid overlapping toxicities, but synergize for efficacy, to get deeper responses. And that's what we're seeing with drugs like selinexor or navtemadlin, which has a great wealth of data at this point, demonstrating that these drugs are active as single agents, but they seem to be even more active in combination. And this is supported by studies that are done in mice that are engineered to have myelofibrosis. And that's where a lot of this comes from. And in primary cells, from people that have been generous to donate their blood cells in the clinics at tertiary care centers. And we take those cells and we experiment, and we figure out how are we going to make better drugs in the future. So I thank those patients who give it seems like a small thing, but it's a huge aspect of how we move this whole machine forward in clinical research. All of that information allows us to say, hey, look, this combination really looks effective. Well, we've got these JAK inhibitors that are already commercially out there. We're going to add this drug that synergizes nicely in these preclinical models and these cells in the dish, and we think it's going to work better than each drug alone. And we'll figure out how to dose them and schedule them to minimize toxicity. And that's really where we're seeing it. So we're seeing selinexor, we're seeing navtemadlin, we're seeing pelabresib, the BET inhibitor, navitoclax, the BCL-XL inhibitor. All of them really look good in combination with ruxolitinib. And as Dr. Jain said, ruxolitinib, because that's really been around the longest, and that's sort of the go-to drug that we combine drugs with. And what we're seeing is we're not even waiting anymore for patients to have failed, the first line of therapy. We're introducing the drugs earlier on. We get confidence in their ability and their toxicity profile, and we say, well, why wait? Why wait for patients to do worse? Why not try to get deeper responses earlier on? And I think the punchline here is we're looking for deeper responses. The deeper we can reduce the disease burden, we believe that the better the patient will be overall, not simply feeling better in smaller spleens, which is important, but less disease cells in their body will hopefully mean longer progression-free survival, longer overall survival. So navtemadlin, selinexor, pelabresib, navitoclax, and imetelstat. There's a whole host of drugs that are aiming to really hit the clone and induce deeper responses.
So we've gotten some patient questions, and one is from Iman N, and they ask, what is the best bet for people not responding to Jakafi or ruxolitinib? Dr. Jain, to sort of broaden this out a little bit, I think a great starting place might be, how do you know which JAK inhibitor might or might not work, and which one to try first for a patient?
So post Jakafi, there are non-JAK inhibitor sort of combinations that get added on to Jakafi. Navtemadlin certainly has data, which is an MDM2 inhibitor. What it does is basically restores the natural cell killing pathway that should happen, but is not working very well for some reason. We've seen patients respond in a post-ruxolitinib setting in terms of their spleen and symptoms. There are other drugs like navitoclax, which is a BCL-XL inhibitor, again showing responses in about 1/3 of the patients who were not having a good response to Jakafi by itself or ruxolitinib by itself. Pelabresib, which is a BET inhibitor, and there's other BET inhibitors in the pipeline that are being developed with slightly different nuances as to their conformation and how they inhibit the pathway, are some of the drugs that are, or a category of drugs that look promising and worth looking forward to. Imetelstat has emerging data. So imetelstat is slightly different in the way it works. It basically inhibits the telomerase activity, which is sort of, one of the reasons we think what happens in myelofibrosis or leads to that, even though the telomerase length may be not as long or in fact is short, but the telomerase activity tends to be high, and that's what imetelstat inhibits. And a lot of data is emerging with that drug in the context of myelofibrosis. I'm sure I'm missing some here, and that's not for the lack of preference, but it's probably just not coming to me right now. Selinexor is another one that Dr. Mascarenhas already mentioned about. So if I can get, I mean, this is what I would tell my patients, like if we can get our hands on to one of these combination clinical trials at that time, that would be my first go-to option. If for any reason there's no clinical trial option that is available after ruxolitinib or Jakafi, then obviously there's options of other JAK inhibitors that I guess we discussed earlier on with regards to either fedratinib or pacritinib and hopefully soon momelotinib, that may still benefit patients even though they have not responded to a frontline, or they have stopped responding to or did not achieve benefit from Jakafi as a frontline JAK inhibitor.
Just on the note of transplant, because that is such a huge topic for so many people and they hear so much about it, in the context of the landscape changing so quickly, do you feel that you and other specialists in the field will be recommending transplant less to people? And I know this is probably a very individual response, but just as an overall high level look with everything happening, what's the trend there?
Well, I actually think of it the other way. I think we have, by virtue of having more effective treatment strategies to improve spleen and symptoms and get a disease response, we may be perhaps able to take more patients to transplant as a more curative therapy later on. A lot of times, for example, lack of spleen response or poor performance status by virtue of a lot of symptoms or disease advancement into a more aggressive disease pattern headed towards leukemia and things like that, they become, in fact, barriers to transplant. And I think having more options in the future will allow us to take more of these patients to transplant. I mean, we've seen a lot of advances with a lot of these options. What we have not seen so far as such, and hopefully we will in future, is sort of the curative potential. I mean, all of these drugs have a lot of advantage in terms of improving spleen, symptoms, cytopenias, but So far, we have not had definitive improvement or getting rid of the abnormal stem cell clone. And that's something that, at least so far, we only achieve with a stem cell transplant. So at some point, as long as patients are eligible for transplant, and that is something that would fit their life wishes in general, that would be a consolidative or a potentially curative option to consider. And I think more treatments or better treatments, better non-transplant treatments will only get more patients to something more curative like a transplant.
Dr. Mascarenhas, anything to add to that?
I couldn't have said it better myself. I totally agree.
Thank you, Dr. Jain. Moving on, we need to talk about when is it right for a patient to seek a second opinion during this time of figuring out what the right treatment options are.
Sure. So, I think, well, the right answer always is now, is you should see a second opinion now, I think, in the terms of, I don't think it ever hurts to seek the second opinion at the time of diagnosis to confirm the diagnosis. There's a lot of heterogeneity in the way these diseases can present, and sometimes there's overlaps and there's nuances. I think it's important to seek a second opinion because you may be a patient who should be considered for bone marrow transplant, the only curative option we have. And sometimes that's really delayed too late, and the patient misses that window of opportunity. And for some patients that may not be, on their plate, but having that discussion is really important. I think if you're lucky enough to live in like a metropolitan area where I am, you could easily see, I don't recommend seeing lots of different people, that can be problematic, but I think getting a second opinion at each stage, maybe at the time of diagnosis, maybe if you're not doing well on your first therapy and there's consideration of second therapies, it really never hurts to get a second opinion. And I would really stress that if you have a physician that gives you pushback about getting a second opinion or comes across negatively, you might want to find another physician, because really it shouldn't be an ego thing to the physician. He or she who's caring for you, it really is your life, and you're dealing with cancer. You should feel free and feel confident that a second opinion is not a reflection of your treating physician. It's getting more information, and the more information you have, the better the outcome.
I agree with that 100%. I mean, I think the MPN community is small, but also very well knit, and I think we work very closely together. And I mean, I've asked my patients, and I've set second opinions up for them if they needed to go. And I've sent patients to Dr. Mascarenhas and to others if there is, for example, a clinical trial opportunity that we may not have and they may have. Sometimes it's better for them to hear it from more than one people, because a lot of things we do similarly, but there's also some that we may have different perspectives about. I mean, it's a common joke. If you ask 10 MPN experts, you'll get 12 different opinions. And not because anything is right or wrong. It's just, there may be a slight difference in what our prior experience with a particular strategy was, or how, what our perspective about a particular strategy may be. And I think all those are important things.
All right, so thank you so much, Dr. Jain, for that on the second opinion. Ashley, let's go back to when people really want to explore clinical trials, right? We've talked about a whole bunch of the options in myelofibrosis, but when you actually come down to the day-to-day of needing to find one or stay on one, there's so many questions I think that we all encounter. And we know that, clinicaltrials.gov is out there. It's a little bit, to navigate. And that's why the LLS's Clinical Trial Support Center is so important. So what are your top recommendations in terms of looking for clinical trials?
Absolutely. I think so often people try to go about it on their own, and looking at clinicaltrials.gov is most definitely the most comprehensive database out there of all clinical trials. But in addition to cancer clinical trials, there are also clinical trials for all types of disorders and diagnoses on clinicaltrials.gov. It's not always easy to hone in on what you need as far as past treatments or other medical history that you might have. And so it can really make it a challenging situation to find clinical trials that are actually applicable to you as an individual as you're looking through. And so we certainly recommend, we always encourage reaching out to the Leukemia and Lymphoma Society We have the Clinical Trial Support Center, which, as you mentioned, was developed as a response to help patients find clinical trials that are appropriate and to them as a unique individual. It is a free service that is staffed by nurses who have expertise in blood cancers and clinical trials. And the nurse navigators are available, and we connect one-on-one with patients, with caregivers, or even other healthcare providers who may need to learn more about potential clinical trial options. And when we do that, we reach out, we find more about the patient's diagnosis, we learn about any past treatment they may have had, or if they haven't had any past treatment, and also find out a bit about their medical history, because all of those factors will play into a patient's eligibility to participate in a clinical trial. We also take a long time finding out about patient preferences and any unique obstacles that could hinder or drive participation in clinical trials, so that we can help tailor some of the support and the resources that we're able to provide, so that patients can overcome some of those barriers that may be in place. After we've generated all of that information and really taken the time to get to know the patients, we do produce an individualized clinical trial search. And again, that could be related to geography, what's in the patient's area, or again, preferences, what matters most to the patient. Is this something that they're really not interested in spending a long time in the hospital if they can avoid it? And so we'll definitely look at all of those and really produce a list that can be taken back and reviewed with their treatment team, so that that can be part of the informed decision making with the patient's next steps, as far as that care team and what comes next. And so that's kind of what we do as the Clinical Trial Support Center, and we are available for all blood cancers, including myelofibrosis and other MPNs. And I really think it's important to know, we're available and patients can reach out, because even though half of the clinical trials that are ongoing are cancer clinical trials, sadly, only about 5% of cancer patients actually enroll or participate in a clinical trial. And so there's so much opportunity out there, and we really love to help overcome any barriers that patients might have, so that they can consider participating.
I know we've covered a lot of ground in a short amount of time. We'll start with you, Dr. Mascarenhas. If there's one thing, or one top message you'd like for our audience of patients and care partners to walk away from, what would that be?
I think hopefully to share my enthusiasm and optimism that we are making advances, and that there is a brighter future, and that I'm really genuinely excited about that, and to embrace the opportunity of clinical trials. That clinical trials sometimes are looked at as for other people, but they may actually be important for you, and to talk to your physicians. And you may not go through with it, but learning about it, I think, and exploring it is important for each patient.
I love that, right? Because at least then everyone can make the best decision for themselves, right? Dr. Jain, how about you?
I think I'll sort of add to that to say that it's never a wrong time to see a specialist or to see someone else if something is not working out. I mean, as Mary said, that some of the symptoms didn't really come out as being very specific, but being an advocate for yourself and getting a few things done, or maybe seeing another doctor, or getting a second opinion, as maybe never hesitate to do that. I'll also pitch in as a transplanter. I also am obliged to pitch in that getting an opinion about transplant and at what course in your disease that may make sense is an important question to address. You don't have to wait until you're progressing or not responding to drugs. I think that question needs to be addressed and outlined in an early appointment, rather than waiting for too long.
Thank you for that, Dr. Jain. Really appreciate it. Ashley, would love to hear your top takeaway for people.
Absolutely. I really want to echo what's already been said. I think it's so important to consider clinical trials as part of the treatment plan. And again, even if they may not be an option at that particular moment, it's important to be informed and be able to look at all of those components as you're making an informed decision about the treatment plan with your providers. And also, just as a representative of the Leukemia and Lymphoma Society, would really encourage any patient with myelofibrosis or any MPN to reach out. The Leukemia and Lymphoma Society has so many resources available, including clinical trial support, but also so many others that we would really enjoy the opportunity to connect and provide those resources to patients.
And I love that the CTSC, the Clinical Trial Support Center, really great, because as we know, clinicaltrials.gov very comprehensive, but maybe not the most user-friendly for people like me. So thank you so much, Ashley. And finally, Mary, really appreciate you joining us and helping to lead this discussion. What is your top message for other myelofibrosis patients and their care partners?
Just sitting in on this conversation, continue to have hope, continue to want to thrive and live. You know, at the beginning of my journey with myelofibrosis, I was told I'd be dead by age 72. And that was only 6 years ago. And now they're saying you could outlive this. You could die with this, not of it. And hearing both Dr. Jain and Dr. Mascarenhas talk today about all these combination therapies and how they actually might get us to the cure was very exciting for me. Thank you.
Thank you so much, Mary. Your story is so powerful. It's also on our platform, so feel free to check out Mary's story in detail there at thepatientstory.com. Thank you also to Ashley from the Leukemia Lymphoma Society, to Dr. Jain and Dr. Mascarenhas for the work that you're doing to really push forward research and day-to-day in helping patients and their family members better understand their options in myelofibrosis and in MPNs altogether. I hope that you at home were able to take away something, at least something that was really key for you, because that's our goal, is to empower you in your own care. And speaking of that, you know, there are so many topics that we'd like to cover to help you navigate whatever you're going through. So please take the time to fill out the survey that will pop up once this window closes. Again, it'll only take a few minutes and it'll automatically enter you into a raffle for one of our $50 Amazon gift cards. So we are so excited you were able to join, and we look forward to seeing you at a future program. I'm Stephanie Chuang with The Patient Story, hoping you have a wonderful rest of your day.